for inviting me today. So I think after two wonderful talks by dear colleague and friend Adrian and followed by another dear colleague, Dr. Pramod, I will be looking at how the trials have been done and especially looking at this dogma of early versus delayed renal replacement therapy. Are we really choosing the right patient? So this is a very recent trial which a study. I won't say it's a randomized controlled trial. In fact, it's a post hoc analysis of a large randomized controlled trial, famously known as IDLE ICU, which was recently published in Critical Care. It's an open access journal, so all the articles are free. So if you want to read this article afterwards, I will definitely recommend you to go and read the article, especially the supplement part, where the Barber and colleagues actually did this post hoc analysis by looking at the timing of the initiation of renal replacement therapy by doing this post hoc analysis of IDLE ICU. We know there is an ongoing debate, especially the patients where there are no urgent indications like hyperkalemia, metabolic acidosis, or fluid overload, how to manage renal replacement therapy for these severe acute kidney injury patients. When to start, when not to start, as I think one of the slide of Dr. Pramod try to highlight, early is something is something over. But yes, I saw that year was 2020, probably the last trial where it came. But I think this particular small post hoc analysis tried to challenge that dogma. Are we selecting the right patients for these big randomized control trials? And the slide which also he tried to show and put focus on these landmark trials of renal replacement therapy, especially related to the timing of renal replacement therapy, starting from BOML to START AKI, where either they try to fail to show any difference between early versus late renal replacement therapy, or they were dichotomy of some benefit or some harm by using early therapy versus a late renal replacement therapy. But if we look a little bit deeper into these trials, sorry for this busy slide, what you will find is the way these trials were designed. The inclusion criteria were primarily by looking at the stage 3 acute kidney injury patients. For IDLE ICU, this was a rifle criteria, which was stage F, which is very similar to our KDIGO stage 3 AKI. So these, the inclusion criteria for most of these patients, most of the patients who were enrolled in these timing of renal replacement therapy trials were KDIGO stage 3 or equivalent rifle stage F. But looking deeper, and I think you must have seen this slide quite many times, but looking deeper, earlier was, the group which was randomized to earlier were more or less homogeneous. So most of these patients who were unselected acute kidney injury patients were randomized quite early. And the patients who were randomized for these earlier cohort were actually given the renal replacement therapy, while the patients who were randomized to later or the late or delayed renal replacement therapy, some patients actually did not receive, and in fact 50% of the patients in AKIKI trial did not receive renal replacement therapy. And that is primarily because looking at this area, which is this particular part where the time duration where they decided to start late therapy. And most important criteria to decide a delayed renal replacement therapy was looking at the urea. So any urea which was higher than 100 was actually taken as one of the indication to start renal replacement therapy in these patients. So if patients were delayed for more than 48 hours, many of these patients recover spontaneously and did not require renal replacement therapy. And that is one of the main reason that there was no mortality benefit, which was found out at least in AKIKI and in IDLE ICU trial, where they actually try to have the delayed group at least 48 hours and later. So this particular trial, what they did was looking at the same hypothesis that severity of acute kidney injury is probably different when they categorize these patients of KDIGO into either creatinine elevation or urine output criteria. So they separated, as we know, KDIGO has two elements. One is elevation of creatinine and the other is a urine output. So they try to created two subgroups where they choose the criteria either basis on the creatinine or basis on the urine output. As we know, there is, in the ITEL ICU criteria, they actually use failure, which was similar to KDIGO stage 3 as one of the inclusion criteria. Tapas, can you help me out with
I'm trying. I'm doing it. Requesting everybody, please mute your speaker audio. Yeah, just.
Thank you. So they actually created three groups. One was elevated creatinine. Second was reduced urine output, and the final group was both either increased creatinine and decreased urine output. And what they found was the primary outcome, which was the same primary outcome which was there for ideal ICU trial, ideal ICU randomized control trial, day 90 mortality. And the secondary points, there were a lot of secondary endpoints. They looked at ICU hospital mortality, length of stay, renal replacement therapy free days, and renal replacement therapy dependence on the hospital discharge. They did intention to treat principle as the only original randomized control trial. They did a logistic regression, especially looking at day 90 mortality as an independent variable, and that did a binary or a multivariate analysis looking at various confounding factors. So they finally found out this match group of 479 patients, categorizing into high elevated creatinine, decreased urine output, or matching both the criteria. So nearly 480 patients were enrolled. Not enrolled, were finally taken up for this study. The one which are highlighted one in this particular table, patient characteristics, the one which are colored in the blue, light blue shade, are actually the significant one. So obviously the patient who had decreased urine output had much higher rate of chronic renal failure and chronic liver disease, while there were also higher rate of nosocomial or hospital acquired infections, and there was also little bit higher severity as what was expected in patients who had a decreased urine output as compared to the patients who had a elevated creatinine as the initial criteria for start of renal replacement therapy. Again, looking at the creatinine, obviously the patient who had elevated creatinine was significantly higher elevated creatinine as a criteria for start of renal replacement therapy. But in patients with urine output decrease, the acidosis were relatively lower, and the fluid balance obviously was much higher because of oliguria or anuria in these patients. Other than that, there were no much difference in patient characteristics. What they found was in this particular post-hoc analysis, in patients in the group 1, where the criteria for selection of renal replacement therapy of early versus delayed, in patients where the elevated creatinine was chosen, there was significantly higher mortality in patients where early renal replacement therapy was done. So this was almost matching what was find out in the original trial also, that in starting an early replacement therapy did not find any difference. But here, if the initial criteria was actually an elevated creatinine, there was in fact higher mortality by using an early renal replacement therapy. But what was very surprising and interesting also, in patients where the criteria for starting the renal replacement therapy was actually decreased urine output, there were almost 10% but non-significant difference in actually reduced mortality when early renal replacement therapy was started in these patients. So this was not originally proven because there was no subgroup analysis in the primary trial, but in the post-hoc trial, what they found was, if depending upon how you are phenotyping these patients, if the patient has an early elevated creatinine to start with renal replacement therapy, higher mortality with early, while in patients with decreased urine output or oliguria, the lower mortality with early renal replacement therapy. But again, this was a non-significant value. And what about secondary endpoints? There was no much difference in both early versus delayed group in all of the 3 groups for renal replacement therapy, for looking at RRT free days or length of stay. So there was no difference in ICU mortality also, or even delayed mortality. But yes, looking at ICU mortality specifically, there was higher but non-significant difference in early replacement therapy for elevated creatinine, and for patients where decreased urine output, there was non-significant difference in the ICU mortality, again in the patients with the delayed renal replacement therapy. Again, something which I really liked about how they discussed and how they tried to went deeper into this hypothesis. This was something which was not discussed in the original trial. The KIDGO was, as I showed, was the main reason or the main indication for classification, but we know KIDGO was never validated for selection of patients of renal replacement therapy. They have been much more validated extensively into prognostication of these patients rather than selection of these patients as a trigger of renal replacement therapy. And I think that where there is still a dogma of early versus late by using a KIDGO or stage 3 AKI by using KIDGO or rifle classification. What was actually important, we understand that creatinine, by just taking as an indication for starting delay or early renal replacement therapy, has its own limitation. We know there is a lag period, especially patients who are critically ill. We see if they are non-oliguric, there is certain days or hours of elevation of creatinine, or it continues to peak till it starts coming down, as compared to the patient who are relatively much sicker with the oliguria. And these are the patients who have actually higher amount of fluid balance. So there are a lot of confounding factors which can explain why the patient actually with oliguria and uria are getting benefit by starting renal replacement therapy early, while as compared to the patient with elevated creatinine, where we are getting the same signal as has been given by the large randomized control trial, that there are certain patients who can get better without actually starting renal replacement therapy, and maybe renal replacement therapy is adding up to harm of these patients. So it's very interesting to see whether unselected group of patients for acute kidney injury, which is like a syndrome as what we know about sepsis and ARDS. So again, acute kidney injury is more of a syndrome. So there are various subclassifications or subphenotypes which we need to identify. And this hypothesis of having a lag effect with creatinine can be actually proven for these patients. So urine output is a good criteria. What they proposed was to consider, selecting certain patients for starting a renal replacement therapy. Again, so that what they suggested for actually looking at precision-based treatment, there is a chance where we should try to do some phenotyping, but how? Whether these criteria of selecting elevated creatinine or urine output are actually good enough criteria to further, do randomized control trials looking these criteria, or we should take some other biomarkers or other, indices as what proposed by Adrian also in his presentation, that there are now good tools which we can use to predict certain amount of progression of acute kidney injury. Probably future will be of these trials, but yes, before I end and conclude about this particular trial, this was just an hypothesis generation. It was not a randomized control trial. It was a post-hoc analysis. So obviously it was not enough powered to show these outcome differences, which has been shown. And similarly for a small group of patients, while we see that there was a 10% difference between early and late for patients with oliguria, but it was not enough power to show any statistical difference. Delayed renal replacement therapy at 48 hours was arbitrary, as what we have seen. Could we have delayed? And that what has been proven in the recent trial, that even delaying it more than 48 hours will not be as harmful as what we think. So lack of use of biomarkers is something which we should consider, and probably in the future, it's really, rather than selecting or rather unselected group of acute kidney injury patients, we should consider use of either biomarkers or these so-called laboratory markers to consider to select certain amount of patients who may get benefit with renal replacement therapy. And as I said, it's a hypothesis generation trial rather than a confirmatory. So causality is not proven by looking at the end result of this trial as what we know as a post-hoc analysis. So it's a major limitation which we have to consider before taking this into our bedside practice. But yes, this gives an idea, or this challenge the dogma of early versus late, or at least what has been given a sort of obituary by the large randomized control trial. And we should consider selecting certain amount of patients where we may still have benefit by using early renal replacement therapy, and that where precision-based medicine will have a edge over using just the knowledge which is coming from the randomized control trial. So there is a need for phenotyping for deciding that timing and better selection of patients for renal replacement therapy. That's what the trial actually concluded. That's all. Thank you. These are my email and my social media. So if someone wants to have these slides, please reach out to me. And I end with this, Asia Pacific Sepsis Alliance, a very beautiful infographic which talks about the sepsis, and these are the various languages where to create that advocacy and awareness. We are actually can give this to again patients to talk about sepsis on World Sepsis Day. I think this is a very good slide to end my presentation. Thank you.
Thank you, Dr. Nasa, for well analyzed and also summarized about this clinical, very important clinical question what we are facing. Now the discussion is open for the forum. Dr. Lobo, Dr. Guru, Dr. Wong.
May I?
Professor Bhattacharya, kindly share your opinions as well as comments about this study as well as the take-home message.
Yeah, thank you, Dr. Nasa. Some things that stood out for me from the journal class that you gave us. One is that if one looks at creatinine alone, then early did not seem to help. In fact, it was associated with a higher mortality. Also, in the second group, that had only urine output criteria, the overall mortality is higher than in the other two groups. It went as high as 67%. So that to me may mean, and because you did show that one slide, that if one is looking at urine output only, then perhaps those patients are more fluid overloaded. We know that at 10 children, a 10% increase in fluid overload significantly impacts mortality. So if there is fluid overload, then mortality is going to be impacted. And maybe that's the group where, so if you start early, keep these patients dry, going with what Dr. Adrian Wong said earlier, better assessment at the bedside of fluid status, and start renal replacement therapy, and maybe guide the renal replacement therapy with better tools. The era of precision medicine, as you said, has come, and that is what may make a difference in the future to how we give renal replacement therapy and what will be the goals that we'll be taking. And the third bit is that this study is a little different because the group which had only urine output criteria had the highest mortality. And the University of Pittsburgh study, which was published some years ago, looked at up to 1 year and I think it was a study of about 8,000 patients. They found that the worst mortality was in patients who, of course, they were not looking at renal replacement, they were looking at mortality as a whole, that if patients fulfilled both the creatinine and the urine output criteria, then that was the group that did worst. So there's a little difference over here in that respect, and it seems to indicate that fluid overload plays a significant role in mortality, and that perhaps if the renal replacement therapy is directed towards getting patients drier, keeping them optimized in terms of fluid, we will do better. Thank you.
I think Dr. Valentin or Dr. Lobo, it's a very, very big finding which you did. It's a very important finding which you picked up by looking at the fluid part, which I try to also highlight. A positive fluid balance, especially in patients with oliguria, that's what we expected also, because obviously they were oliguric as compared to the patients which were non-oliguric and just had an elevation of creatinine. I think one of the major risk factors which could have been led to higher mortality in these patients. Also, they were much more severely ill, as represented by the higher SOFA score in these patients. Again, as it's a post-hoc analysis, so obviously these were big confounding factors, which they also agreed. And again, it's a hypothesis generating trial, but yes, these are the certain patients we also consider at the bedside to start early renal replacement therapy rather than waiting for a definitive indication. And I agree with you.
Yeah. So one comment, there is a question also related to that. Where can we feed the early biomarkers rather than KDIGO? Can we just have the biomarkers to decide whether to start RRT early or very early, something like that? What is the current position, Dr. Nasa?
I think it's a very interesting one, which is, I think, probably future where we need to phenotype as what we have started doing for ARDS and sepsis. This is something we need to do probably in the future, but there are no large randomized controlled trial by looking at biomarkers and then selection of renal replacement therapy at present. It's more of an hypothesis generation at present, but yes, this type of trials actually allow us to think rather than going for large RCT by just selecting or unselected group of patients. We should start selecting few patients, where start doing subphenotyping in these patients and start looking at these therapies by subphenotyping rather than unselected patients. At present, in my knowledge, I don't think there is a large randomized control trial which has been done by using biomarkers and timing of renal replacement therapy.
The only trial which included NGAL was ELEN, and that's the only study which actually has results which fly in the face of all the other trials. And it's been criticized. It's a single center study and many other drawbacks.
It was a criticism, big criticism for them. Yeah.
Yeah. Thank you. Dr. Guru, you were sharing something.
Yeah, this is again, Prashant, thanks for reviewing a wonderful research, as well as Dr. Lobo for your, as usual, pinpointed and very interesting so-called analysis of every study. So the elephant in the room for all of us to understand here is that there are biomarkers, probably 50 plus biomarkers for last 50 years. And then what we are trying to do is just keep pausing and finding more biomarkers and adding into the fuel for more fire, but not really understanding how to utilize them. So the take-home message, the biomarkers are not really available to make any decision at the bedside. That's number one. Number two is that the decision regarding early versus late should be individualized depending upon the demand versus supply of the patient's need at a given moment. So if you are asking me that I am having urine output of nil, but that means my GFR is 0, I do not care about what your creatinine is. If I knew that my patient is not getting any urine output, and then inotropic support is keep increasing, that, and then he's a octogenarian starting with the CKD stage 3, my chances of this patient going for a established renal failure as well as going for renal replacement therapy is very, very high. And on the top of that, if I'm struggling with my ventilations and then the patient is puffed like a frog, then I don't have to wait and follow the randomized control trial when I need to start the dialysis. These patients need dialysis because that will give me a lot of help. So what I'm trying to say is that it's all about finding the patient profile and then deciding what is important and when you wanted to do what. Because none of these trials really, even if the future is going to give you a clean path to decide what you need to do. Rather, the focus, this is again my opinion, I might be completely wrong, the focus of the care process should be to find out an agent which can reverse the AKI in general. That should be the thing, similar to ARDS. Because once the things are established, everything else is the support, and you have to cross your finger till the kidney regenerates and making urine. That should be fine. Similarly, if the patient is not making urine and you are already given 500 milligram of diuretics, please don't another 500. It's not going to work. The patient kidney is established. Just accept it and call your nephrologist and start the dialysis if it's needed. That's my point.
What a